in yet another important episode from ETHealthworld. This is World Heart Day special webinar. The topic is World Heart Day Alert. Is India on the brink of a cardiovascular collapse? Every minute, 8 Indians lose their lives to cardiovascular disease, and that is one in every 3 deaths in the country. So, what's even more alarming, it's no longer just the elderly. The young professionals in their 30s and 40s are falling victim of to this silent killer. Stress, sedentary lifestyles, pollution, late diagnosis, whatever it may be, the crisis is real and it is accelerating. Today, we are joined by some of the top cardiologists, experts to discuss how we can prevent a looming public health disaster and strengthen India's heart health.
Thanks so much, sir. These are all very busy days for all of you to be sparing this very important public messaging panel discussion. We already have a very good response. Coming to you, sir, Dr. Seth, your initial comments on exactly what you are seeing as important trends in heart care. We have seen today's paper in Times of India. There is a mention about how children are getting triglycerides which are way above the normal range. Are we like doing a lot of studies so these things are coming out, or do you think there is a absolute looming danger there?
Before the studies, let's just understand the predicament that India is in. And that's very clear that we are the world's capital of heart attacks and heart disease. It is growing. While deaths from heart disease decreased in the West over the last 30 years, we increased heart diseases by 300%, but we also increased it by 200% in the young individuals. And the predicament is that when we look at the next 30 and 40 years ahead of us, if we don't take action and understand every aspect of it, we will be in a very difficult situation where majority of our youth and half the country, as we always keep saying, is young individuals less than 40, which are taking this country forward. They are already predisposed to heart disease, and heart disease is growing in them. And then age also catches up, causing increased heart disease as time goes on, including the risk factors and the duration of risk factors which exist. So 20, 30 years later, we will actually have an explosion of heart disease. So we need to take things in our hand. So, when you raise these issues, it's always that each one of us, even sitting here, is predisposed to having heart disease. And I would not say it's a genetic predisposition, because we then take away our responsibilities away. I would have to say very clearly that the risk factors of heart disease continue to increase in our country. Diabetes has increased, hypertension has increased, smoking has increased. We are the world's capital, by the way, of all this. Tobacco chewing is on the rise, alcohol has increased, obesity has increased. You already know that our own Prime Minister has emphasized this aspect of obesity and being overweight in a very important manner for the whole country. And add to that, pollution, another important risk factor, has increased. Stresses have increased. And therefore, we just say, we are not genetically predisposed. We actually have the highest proportion of risk factors which are continuing to increase than any other countries across the world, I would say, apart from our region and some of the underdeveloped countries.
So thanks so much, sir, for that very important introduction that rolls into the discussion. Basically, we missed mentioning and introducing Dr. Aditi Singhvi. Apologies, ma'am, because of that fire alarm. So Dr. Aditi Singhvi is consultant clinical lead, adult heart failure and transplant in cardiology for Narayana Health. Thank you so much, ma'am, for joining us. So I'll also loop in the same question to you, Dr. Singhvi. What has been your observations so far as the trends are going? We have been seeing new launches in congestive heart failure drugs. There are so many more, inventions happening on genetically predisposed heart conditions. Do you think those are the ones which probably can give us new areas where controls can be handled better?
Thank you so much for that question. And that's a great question and very pertinent as well. Um, but as we all know, prevention is better than cure. So, definitely, there are newer treatments coming, newer medications, newer devices, and definitely people with heart disease do have better quality of life and longer survival as well compared to, say, a decade ago. So the risk of dying from a heart attack or risk of dying from heart failure has definitely reduced. People have better lives, and you can have an almost normal life even after having a stent or having bypass surgery. But to also corroborate what Dr. Seth has said, definitely we need to focus more on prevention than on treatment. And I think as a country, that is where our focus should lie, is focusing more on prevention of heart disease itself. So that includes tackling risk factors like high blood pressure, diabetes, cholesterol. That is where we should focus as a nation, as well as addressing lifestyle factors and environmental factors. So, making changes in our diet so there's less refined carbohydrates, less processed foods, less artificial and added sugars in our diet, increasing exercise, reducing smoking, alcohol, vaping as a public, I feel that is where our focuses should lie. And there are a lot of public policies, etc., that can be placed to help with these initiatives as well.
Right. No, so also earlier, we used to think about heart as like a condition that probably will bother us beyond 50s or 60s and into 70s. Now that scale has actually moved much into the 30s, and then it became, now we are seeing kids also getting higher triglycerides. What is this indicating? I mean, obviously you mentioned about public messaging. uh, in terms of shooting down the trouble like triglycerides. I mean, how do we handle that part? Do you think the government machinery needs to be much more agile on this? The rural sector probably needs to be really stepped up.
So I feel we have to take a multi-pronged approach where the individual, public, and government, everyone has a role to play in this. So from the individual side as well, we are seeing an increase in this because of a lot of changes in our lifestyle and environment. There has been more urbanization, because of which less activity, more sedentary jobs is more sedentary jobs. We are seeing changes in diet have taken place a lot. So from our traditional balanced diet, now there is more refined carbohydrates, fried food, and processed foods in our diet
Yeah.
now. So those definitely have a big role to play. Stress has also increased a lot, especially post pandemic. We're seeing a lot of stress, anxiety, and mental health issues amongst younger people as well. Post pandemic, there has also been an increase in substance use like smoking, vaping, and alcohol. Then, from an environmental perspective, as well as was mentioned earlier, smokeless tobacco, that is a problem that is seen more in
Yeah.
India. Air pollution is also very predominant, especially in the metro cities. And now, even in rural and semi urban areas, we are seeing more air pollution. So all of these factors have to be addressed, and definitely individual and public has a role to play in this, and the government can also play a role in that, like increasing public awareness. For
Right.
example, increasing public awareness helped with eradicating polio. Similarly, we need to
Yeah.
shift our focus now from infectious diseases, which 10, 15 years ago was definitely a big public health problem, but now these non-communicable diseases are also becoming a big public health burden. So we should focus on raising awareness about high blood pressure, diabetes, cholesterol, and at the grassroots level in primary health centers, there should be screening for blood pressure, cholesterol, sugar, along with the traditional focus on vaccinations, etc.
Yeah, that's an important point. Dr. Tyagi, you are at a very important position as the president of Cardiological Society of India. Uh, uh, what has been the approach that you have seen both from the private sector and the government agencies. Do you think because of this like a wave of heart issues that we have been seeing maybe in the last 4 or 5 years, there has been some acceleration in the moves of prevention, as Dr. Aditi just mentioned?
As Dr. Seth emphasized, that there are multiple risk factors, and most of these risk factors, I think, are individual centered, like smoking, diet, exercise, stress, and obesity, and everything. So while we have to have a community-based approach or national approach for prevention of heart diseases, most important for every person is to take care of their
Yeah.
own health as well as heart health, because we know that coronary artery disease in India is occurs at an earlier age, and have we have a very high risk burden. We have diabetes, smoking, and several pollution, which are one of the important risk factor. Now, pollution is considered as risk factor as similar to smoking, and we have a higher case fatality rate, and 10 years earlier age of onset of myocardial infarction occurring as compared to the Western population. So we have an early age of onset of these serious ailments. And as you pointed out, Dr. Aditi Singhvi, that why these heart failure occurring at an earlier age. One of the most important factor in our country, that every third person, adult person, is
Yes.
having high blood pressure, which is the commonest heart disease, not angina or heart attack. They heart failure. They are result of these factors. Every third person in India is having high blood pressure, and most of these do not are not aware that they are having high blood pressure. Even when they are aware of their high blood pressure, their blood pressure is not optimally controlled. They have, and once they start the medicine, they have to continue it long term, life maybe lifelong. Many of the times we have seen that patients who are given antihypertensive medications, once they are started on medicines and their hypertension improves, they think that they are cured and they may leave medicine. Similarly, similar thing happens for cholesterol medicine, that is statins.
Yeah.
As soon as the cholesterol comes under near normal, they leave
Hmm.
their drugs, and the cholesterol bounces back to its pre-level. And that is very, very harmful. We know that at the deposition of cholesterol inside the arteries starts at an early age, even young age. So one has to start taking action from a younger age. The diet from the school age, and then all these risk factors, smoking, lack of activity. The children now are more focused on in the front of television sets and video games as compared to our times when we were doing outdoor games, and that was a part of our daily routine. Even in schools, also they are burdened with the both the stress of the competitive education and getting higher marks. But the games and exercise have very important role in the apart from diet, which we will emphasize that now the diet has emphasizes more of refined sugar. The American Heart Association recommends that 4 to 5 times a day one should have vegetables or fruits. But in India, hardly the fruit consumption is for once in a week or so, not 4 to 5 times in a day.
Yeah.
Similarly, our food consumption, like vegetables, what we do is cook our food and cook it at high temperature so that all the nutrients are lost. We do not eat raw vegetables, which is very essential because the micronutrients are, which are antioxidants, are very important to reduce the risk. So apart from controlling your cholesterol level, your diet, less of hydrogenated, less of fats in your diet, saturated fats, the trans fats are very risky, and trans fats are very commonly used in all the preparations what are done in our food item, maybe biscuits or cookies or samosas or any other these items which are very highly consumed in our country, and they are very, very harmful. We need to be make the people aware that these types of fats, the hydrogenated fat that is called the trans fats, are very harmful. And some of the countries which have banned trans fats have reduced the risk of their heart disease, heart attacks tremendously. So we have to take action in the similar manner.
So, Dr. Seth, I was coming to the point of what Dr. Tyagi was mentioning about, the absolute mismatch between what we see in terms of diet in the US about consumption of fruits, veggies, and what we don't see here. In terms of interventions in in schemes like Ayushman Bharat, do you think there is absolutely a need to make these things known and heard at the block levels, at the more rural areas? Because that is again a ticking time bomb.
Let me just first say, we always keep saying prevention of heart disease, and we keep looking at the government and we keep looking at the
Yeah.
policies. Believe me, that would be only 20% of prevention of heart disease. Because clearly, I'm going to emphasizing again, the heart and prevention of heart disease is in our own hands. And I think the message has to be very clear to the public.
Mm.
Yes, education has to be all around. Awareness has to be a part and parcel of every initiative. Be me as a doctor or a healthcare worker, as or a policy maker, as a nation, we have to keep awareness up. But clearly, 80% is in our hands because what are we talking about? We're talking about an easy accessibility to knowing our own risk factors. If I was to tell you that I know my family history, which is an important risk factor, and the fact that I know I'm smoking and should give it up, and the fact that it just takes me a visit to a general practitioner to lower my cholesterol once in a lifetime, to know my blood pressure twice a year, and to know my sugar, a simple, inexpensive test is all it takes me, then five risk factors I know already. Add to that, I know that I'm overweight or not overweight. I know that I exercise or don't exercise. And I know what I eat, which is all trash. So if I know that, then where is the policies needed to prevent heart attacks? If I was to just exercise 200 minutes a week, which is what, 40 minutes a day, 5 minute warm up, 5 minute build down, 30 minute brisk walking, which all of us, by the way, can do. And even those who say and insist, oh, that I'm so busy at work that I'm going to leave at 7 o'clock in the morning and I come home at 10 o'clock, can actually even walk up and down the stairs in their office, in the staircase, 10 times, and they would have exercised exactly the same. Can decrease the risk of heart attack by 25%. So
Very
if I was to
practical.
say,
Yeah.
that where is the policy? In fact, it is cheaper for me to prevent a heart attack because all I need to do is buy a pair of kids. And I'll be eating much better food. I won't be eating outside food. I would be given up smoking. I would have actually taken less salt and be controlling my blood sugar. I would actually be doing everything which was less expensive than what I would have spent otherwise. So that's my first point. And by the way, not just prevention of heart attacks is in our own hands and feet, but also saving others' lives is in our hands and feet as well. But we'll just come to that because all of us should know basic life support and should not be taking videos of guys collapsing and passing away. We should have actually saved their life at that particular time. And I just suddenly want to say that every person who takes a video of somebody collapsing and then spreads it around has actually done the biggest mistake, not because those were alarming and disturbing visuals, but also the fact that that individual could have saved that life of the person who actually collapsed in front of them. But coming to the where are the policies needed? I think the policies needed are right. Dr. Tyagi mentioned trans fats. We are picking up, and actually the amount of trans fats, it's not the fats which is bad. And everybody else has this misapprehension, oh, motapically, fats are bad. Actually, fats are needed for our body. Every brain cell and every neuron is actually consists of needs fat. It's the type of fats that we eat which is bad. And that's what was saturated fats. That's trans fat. And believe you me, trans fats exist in so much of our food. And it's not just that kachori and the samosas, which anyway are trans fats. It's even packed food which we pick up off the shelves. Biscuits, namkeens, anything, cakes. And yet they're not labeled as trans fats. So we need to be more aware of trans fats, and I say that for the upper society. But as we go downwards, what's needed? Do you believe that heart disease affects all socioeconomic status and is increasing in all socioeconomic status? And by the way, it exists more in the lower socioeconomic status in our country. That's a proven fact worldwide in the developing countries. How do we prevent that? Tobacco in any form is so prevalent and highly prevalent in the low socioeconomic strata and upper. But do you actually, so yes, prevention at grassroots levels will only happen through government policies and government initiatives. After all, that's who can get to the grassroots. Understanding and information needs to be spread all over. But I still don't see how and why we are not having enough information as a national event. As a national event, and I know that we talk about cancers, we know that we talk about smoking and oral cancers, etc. But how many times have you gone to a cinema hall just to be said, "Aap bhi heart attack se mar sakte ho," while sitting here? And that's what we all die of. Cardiovascular disease is the biggest killer. Yet how much time is the emphasis on saying that I could be actually having a heart attack, that you could be having a heart attack? Have you taken your blood pressure? Or have you got a BP and diabetes? What is the messaging? It's so simple. आप अपने आप को केयर कर सकते हो, आप अपने आप को प्रिवेंट कर सकते हो. It's so simple as that. So
Sure.
I am absolutely clear. Let us not blame anybody else. Let's blame ourselves, because we as a nation and as individuals are counteractive. हमको लगता है कि हार्ट अटैक तो उस दोस्त को हुआ, हमको लगता है कि वो जो अस्पताल गया था उसको हार्ट अटैक हुआ, मुझको तो होता ही नहीं है, बिकॉज चोरी भी उसके घर में होती है, मेरे घर में होती नहीं है, तो मेरे को तो इंश्योरेंस लेने की जरूरत नहीं है, सीट बेल्ट तो किसी कोई और लगाता है, मेरे को सीट बेल्ट लगाने की जरूरत नहीं होती है अनलेस की पुलिस ना देख ले. We are, as a nation, counteractive. We don't exercise, by the way, till a heart attack happens. In the West, people exercise so that they prevent heart attacks. हम जब हो जाता है तो पूछते हैं, अच्छा खाना क्या खाना चाहिए, because we had a heart attack. उसके बाद the खाना which is made for me after a heart attack is totally different to what the rest of the family eats, and it's totally a separate food. कि ये तो बीमारों का खाना अब इसको दो क्योंकि इसको हार्ट अटैक हो गया. But what about the other people who are hogging away all the trans fats and never even imagined कि उनको भी हार्ट अटैक हो सकता है just because their relative had a heart attack and they continue to eat that? Exercise be. And I did this survey, by the way, exactly 15 years ago. We published in the Hindustan Times 1,000 morning walkers we surveyed. Majority were above the age of 65. 75% of them had heart problems and had been advised by the doctors to exercise. तो वो कहाँ गए जिन्होंने हार्ट अटैक प्रिवेंट करना था? The ones had already had heart attacks and wanted to walk. I am clear. We as a nation do not want to understand this. If we don't want to understand it, if I don't want to understand it, believe you me, in a week's time, I will have a heart attack, because
Absolutely.
we are all loaded guns and it just needs a trigger pull to trigger that and fire that bomb inside us to have a heart attack. It's as simple as that.
Absolutely great messages, sir. Thank you so much for sharing that. And yeah, each point that you made is well taken. I hope it's all relayed well to our audiences. So touching upon one more topic which has been sprouting up and raising some kind of a controversy. So I'll start with Dr. Tyagi again. Sir, around the time when we were preparing these questions for our expert panel, again, we kept talking about seeing reports about statins and whether it actually it prevents heart attacks. And then some of the journals and some of the newspapers abroad also spoke about statins really not preventing heart attacks. So with our three experts, I'd like to take that up again so that that controversy rests, because some of my friends have also told me that I have been like spacing statin use, like every alternate day I'm taking reduced doses. So what exactly should we be doing about this particular issue? So Dr. Tyagi first.
See, we know that deposition of cholesterol inside the heart arteries occurs because of the LDL cholesterol. LDL cholesterol is the harmful cholesterol, and HDL cholesterol is the beneficial cholesterol, which removes the LDL cholesterol from the heart arteries. And not only heart arteries, but brain arteries, which are causing stroke, the kidney artery, which is causing high blood pressure, the peripheral arteries, all of these, the atherosclerosis is the common component. And atherosclerosis occurs because of the deposition of LDL cholesterol inside the intima of the arteries. And to lower the level of LDL cholesterol, the most important and the safest drug at the moment is the statins, which I like to say that it is the wonder drug of the century, and misinformation has been spread around about the statins. Patients are reluctant to use the statins, and once they are started on statins, they are afraid of starting statins. Even most of the while the most of the medical profession are themselves taking statins, but their patients are afraid of taking statins because of the misinformation that has been spread on the media, that they are having side effects. The side effects are very minimal if they all occur anyway, but the benefit is immense. They not only reduce the plaque formation, deposition of the cholesterol inside the artery, instead, because of their pleiotropic effect, they prevent the development of heart attack. What they do is not only lower the level of LDL cholesterol, but they also prevent the rupture of the plaque, which causes the myocardial infarction. How the myocardial infarction occurs, heart attack occurs, is because of the plaque rupture, plaque of the cholesterol which is there inside the heart artery. When it ruptures, the platelet comes and get deposited on it and form a clot. That clot is responsible for the this heart attack. And the statins not only reduce the level of LDL cholesterol, but they also reduce the chances of developing heart attack. Even if a person on statins develops heart attack, usually it is a milder heart attack, that I would say. But it can occur in a patient who is already on statins, because a lot of our patients who have already got their bypass surgery or angioplasty and have statins, but the chances are reduced if you take statins, and the risk with the statins is very minimal as compared to those persons who are not taking statins. And apart from that, there have been a very important development in the recent years on the drugs which can be used to reduce your LDL cholesterol level, and multiple drugs are now available, but the most beneficial and most and the cheapest drugs are statins at the moment, and have much beneficial effects on the on our deposition of the cholesterol inside the heart. But as Dr. Seth emphasized, and I also said, that our diet is one of the most important thing. What we take inside gets deposited inside us. If we take high saturated fats, if we take trans fats, they will go inside the arteries and clog the arteries and cause buildup of atherosclerosis and causing the blockage, angina, and heart attack. If we
Right.
take more of, similarly, if
Sure.
you take more of salt, then high blood pressure will be higher. So we have to curtail our food intake and to save ourselves from the risk of heart attack and hypertension and heart failure.
Pratibha, you want to go ahead? We have a bunch of other questions also, which are very pertinent.
Yeah, thanks.
Because I
Yeah.
just want to mention where government policies and initiatives should come in.
Yeah.
And while we talked about at grassroots levels, that can only happen with government initiatives and policies at the primary level, in the villages, etc., where early detection of all the risk factors and clear education, which through various health workers can happen. But what's very important on the national level are three things which are missing and needed. One is trans fats, a clear policy on trans fats. It's clear demarcation, mention, and clarity. I mean, after all, we have cigarettes and we have a warning on them. There's no reason why we can't have warning around trans fats and the food which is kept and the content of the trans fats, and it's beyond the level or not. So that's one. The second aspect of national policy revolves and has to start thinking on pollution. It's one of the most important risk factors why we see this growth in young individuals happening of heart disease and heart attacks is because the young individuals are out on the streets like delivering X, Y, Z, going to work in open motorbikes in most polluted cities, and that pollution's on the rise exactly. It has also been seen that हमारा जो कम वाले polluted days है ना, we only talk about pollution when fires are being burnt around our city and say, oh, November is a bad polluted month. Those for the West would be the banned. Nobody would even, everybody would be indoors and every office would be shut. Our best days are already in the worst zones of the West. Our best days throughout. So we are living polluted throughout year, every day of the year, rather than think that एक महीने की pollution आती है. So that's another important point to make. And really, if we're not serious about policies, we can talk as much as we want about many other aspects, saying हम तो carbon points देते हैं, but अगर carbon points से ज़्यादा तो हमारे heart points ज़्यादा होने चाहिए to make us survive in this pollution. And finally, why haven't we created a mandate for every workplace to be heart healthy? Why haven't we created कि एक एटलीस्ट एक ट्रेडमिल अपने ऑफिस में खरीद के, आप बड़े बड़े ऑफिसेज होते हैं उनमें कैंटीन विद समोसास एंड पकौड़ा जरूर होगा, और 15 मिनट मिलेंगे तो एवरी employee is encouraged to sit down and have pakoda, samosas, and banter amongst themselves. But how many of those would have also a room saying, here is a little gym, आपको 15 मिनट मिले हैं तो आप उसमें 15 मिनट एक्सरसाइज कर लो? Why aren't we heart healthy points being given rather than carbon points? Environmental points अच्छे हैं, but why not heart healthy points? I think it should be a mandate, and every employer and every office should make sure that it says we are a heart healthy organization because we do this. And
Yeah.
those are the mandates the policy makers can really have.
Thanks a lot, Dr. Said. As you're talking, I'm thinking what and all I've had. I'm like getting little scared, that, we should keep a track of our health. So taking a cue from what Vikas sir had asked about statins and what Dr. Tyagi had said, I would want to go to Dr. Aditi. Dr. Aditi, as Dr. Tyagi said, statins are wonder drug, and a lot of cardiologists themselves have it. They have placed that. So, can you tell me, are we moving towards more personalized or targeted medicine in cardiology in India? How is it shaping up? Your thoughts on that, please.
Absolutely. In all aspects of medicine, we are moving more towards individualized approach and precision medicine. And definitely even cholesterol management for that matter is moving in that direction. So whereas earlier we would have a hard and fast cutoff that everybody start LDL, which is the bad cholesterol, and HDL, which is the good cholesterol, should be below a certain number. Now we are moving towards risk categories. So really what your cholesterol should be, the LDL and HDL cholesterol depends on what your risk is. So if you're low risk individual, you can probably, your LDL cutoff would be a little higher. So an LDL cutoff of 190 would be taken for an individual who has absolutely no risk factors to start medications, for instance. If you have a low risk, which again, there are different ways of calculating these risks. It depends on your history as well. It depends on your gender, your age, all family history. All of these are taken into consideration. Then your LDL goal will be a little bit lower. If you have more risk factors, then your LDL will be LDL goal will be even lower. And if you have established heart disease, then you have a very high risk of having future heart events, and your LDL goal should be even lower, even less than 55. And in addition to these cutoffs, there is also a percentage that we need to look at. So for instance, if you have established heart attack or stroke, you have established disease, then at least a 50% reduction in your LDL from baseline should be achieved. So it's not just enough to start the statin. We also need to make sure that your LDL is well controlled and you are within that goal. So about 4 to 6 weeks after starting the statin, you should have your LDL checked, your cholesterol checked, and depending on your risk factors, your medications may need to be adjusted. So if you're not at that goal, then more medications need to be added to reach that goal. And there are a lot more medicines out there also now, in addition to statin, to help achieve that goal. And definitely all of that is always in addition to lifestyle changes and dietary changes.
Yeah. So we heard that there's a lot of new drugs, new, nahi, effective drugs have come in and a lot of people are using it. So now let me go to Dr. Said. Dr. Said, with improvements in interventional cardiology and electrophysiology, how has the role of medicine shifted in particularly in acute coronary syndromes and chronic heart disease? Are newer therapies reducing the need for repeated interventions or are they complementary? Because a lot of patients wanted to know about this. So,
So
Dr.
this
Said,
is
yeah.
This is very important question, and we must remember that advancements have happened not just in techniques, tools, and technology, as we say in intervention, but they've also happened in medical therapy. And we've just discussed statins as one of the biggest advancements in medical therapy, but there are others also for both for the treatment of coronary artery disease and heart failure. So we must understand that these are all complementary tools to make sure that a patient gets as well as possible and stays as well as possible for the longest period of time. And we call it outcomes. We want to provide the best outcomes. Just because we do an angioplasty and put a stent into a patient, and if we did not have aggressive medical therapy in addition to what we're doing, he would then end up with a heart attack in the future from another block, which would appear, or for any other reason, would have a worse outcome. So, exactly as we do, we as a responsible interventional cardiologist, and even for a surgeon, it becomes important that whatever patient we treat it as a whole, and we treat the patient and not just the disease as per se. Coronary artery disease is preventable, controllable, but not curable. And we want to understand that. So neither are drugs curing him, neither is angioplasty curing him, and neither is bypass surgery curing him. What we are doing is combining options which exist appropriately for each patient, where medical therapy will always remain the cornerstone of everything we do. Lowering his cholesterol, lowering his risk factors, statins, blood thinners like aspirin or clopidogrel, other agents which have come in, so that we keep him away from destructive and new blockages and treat the ones which are readily threatening to cause a heart attack effectively, and in process of time continue that treatment in a much longer duration of time with regular checkups so that we keep him safe. Surgery comes in also at a stage where we believe that it is needed, so that with three of these, we are able to take care of a 40-year-old person who's developed blockages for his next 30 to 40 years of his lifetime. I want that to be emphasized, and it's not either or. It is a combination of drugs versus any other advancements in technology at the moment. Science is moving in fascinating directions, by the way. We've talked about statins, we talked about LDL lowering agents, we're looking at LPA, which is, by the way, I want to emphasize to your listeners that LPA has become a very important risk factor in our mind, and that science is looking at drugs to not just lower LDL, but LPA. But it's also looking at two important ways of treating hypertension and raised cholesterols. Science is working at saying the drugs which actually lower cholesterol and lower LDL cholesterol with twice a year injections are already there. What we need is more outcome data. Well, once a year injections, just once a year, which would lower the cholesterol for the whole year, are already in phase 2 studies. They would probably lower it for a year and a half, but there'll be once a year injections. There are drugs, by the way, injections looking at control of blood pressure for a 6-month duration and maybe for a year duration. A single injection curing blood pressure. It's all going into RNAs and more genetic drugs. And the way we foresee future in 5 years and 10 years when the outcome studies have come out for these drugs would be that we would be able, with a single injection or with 2 injections a year, control hypertension and control cholesterol. And I think that would be that would be very effective in a manner that at least compliances would be there. The targets would still have to be monitored and supervised, but all we need is science to progress along those lines of prevention. I always keep saying prevention. We talk about progress of science as interventional cardiologists about how much we've done in the last 30 years. It's been fascinating. The journey for me, to which I have also contributed in terms of new techniques and technologies, has been fascinating. But the more I've done it, the more I've realized that mainstay will always be drug therapy. Mainstay will always be making sure we prevent further coronary artery disease and further heart attacks in the individuals who we treat with either angioplasty or bypass surgery.
Thanks a lot, Dr. Said. That was like well explained. Quickly, let me go to Dr. Tyagi here. Sir, Dr. Tyagi, you represent Cardiological Society of India. You're the president. So, when we talk about a lot of medicines, cardiac medicines, statins, whatnot, fixed dose combinations, there are a lot of things. How affordable are these, and how, as a Cardiological Society of India, you're trying to make it affordable? Is there any talk on that space? It's just out of curiosity I'm asking, because medicines are to be affordable. A lot of we have spoken about government schemes here, but as a representative of Cardiological Society of India, what you have to say about affordability of cardiac medicines?
The medicines, India is the world's factory of pharmaceuticals. The medicines are from India are exported to all the western part of the world. And India, we have generic medications available. And now the Prime Minister have opened the Ayushman Bharat scheme and the centers for the medicines. Jan Aushadhi Kendra, where these are available at 80% lower cost. And so simple drugs like statins or aspirin, which are the cornerstone of management, can be available at just less than 10 rupees total cost. The simple aspirin will be available for less than 50 paisa, and statin would be available for 2 or 3 rupees. So they are very well affordable. Person who can take a cigarette or BD or these types of things, they can very well afford to take care if they require these help of these drugs. These are in our country, these drugs are very affordable, even for hypertension. As I mentioned earlier, the commonest heart disease is high blood pressure, and the high blood pressure medicines are being distributed in all the government hospitals, the Jan Arogya Mandirs that have been established by the government, and government have the schemes for the detection of hypertension, cancer, and their targeted medicine therapy, which has been shown to be very effective in several states, particularly in South India. There have been several studies. Punjab, there have been studies by giving them target therapy once they have been started on drug, and when they come back again, their blood pressure is studied, and then medicines given. So very effectively medicines are given, but only thing is to take care that we need to take this medicine regularly, lifelong continuation, and blood pressure, cholesterol, sugar have to be kept under control along with exercise and these factors.
What about
as far as the Cardiological Society of India, we are in the next week itself, we are organizing a Cardio Prevent Conference, International Cardio Prevent Conference in city of Indore, and where the world experts would be gathering to discuss these problem of prevention of heart diseases. And from the Cardiological Society of India, we have done a study where the control of pollution, we have taken a large group of school children and have guided them to control the pollution and spread their message. And that strategy is also proved to be very effective. And American College of Cardiology have given award to Cardiological Society of India for this important work on prevention of pollution education in the school children.
Yeah, thanks a lot for that information. But wanted to know about the registries also, because we had been, like Dr. Said was giving us about what should be the national policy, pollution should be there, transpansion. But I wanted to talk to you, Dr. Tyagi, about the several registries are there, like the National Heart Failure Registry, and there's ACS registry in Mysore. But we don't have a comprehensive nationwide CVD registry. So there is no data. Like the last, if I have to go through, it's 2021 data, which I had actually, quoted in my intro. So with every 18 minutes, people dying of cardiovascular disease, don't we need a comprehensive data? And society like yours, if they can play a role, what kind of role you will be playing? When will we have this data? And how? And I would after Dr. Tyagi comes in, finishes his answer, I want to ask Dr. Seth and Dr. Aditi also. So, how crucial is such a unified registry for tracking the true burden of heart disease? The treatment guidelines and health policy can come in, but we don't have a data. Dr.
The
Tyagi.
the registries have been started by Government of India at the Ministry of Health level, and they are doing this work of registries because this is large. Our country is very large, and the government has to take action, and that they have already started the work on registry. I think with the digitization and these communication method being very well developed, Indian Council of ICMR has to take the lead in developing these registries because they have finances and the means to take the registry work.
I hope the message goes to the right people there, and we would want this to happen. Dr. Aditi, if you can talk about these registries, how helpful it will be for the cardiologists themselves, right? If we have an unified registry, because it will help in follow up, standardization. How do you see this?
Definitely, having data is always helpful, and with data comes a lot of knowledge that can help us understand truly what the burden of disease is. A lot of times, you may get surprises from data also. For example, there may be pockets of the country where you think heart disease is not very prevalent, but once we get data, we realize that it is prevalent, and so on. And you might see certain trends as well, like certain demographics or certain communities that are more prone to heart disease or less prone to heart disease, and in the long run trying to understand outcomes also, what treatment works best where and what treatment can be implemented best where. All that information can be gotten from registries. As of right now, there is not a national registry per se, but there are several centers and there are several hospitals that have come together to put together registry data. For example, from Chennai, there is a very good MI registry, that is myocardial infarction registry, where they have looked into their own door to balloon times. That is trying to understand how quickly a person gets a stent after a heart attack. And that is really crucial to understand how we are doing as healthcare providers as well, where we can make changes, what we can improve, and how things can be made better going forward, going into the future. So definitely data is extremely important.
Dr. Seth, I have asked a question, but I want to add another angle also. Is there a role for private hospitals here? Why just ICMR and research institution? Because you get a lot of the private hospitals also get a lot of data. So how can this be a collaborative effort so that a registry is there for us as a country for CVD?
Okay, I'll just tell you one simple fact. There is not a scoring system for coronary artery disease which guides us to the target vessels for Indians, and we rely on the Western figures and extrapolate that into 1.5 times. One of the reasons to understand is that a registry over a period of time which looks at outcomes requires follow-up, and a very systematic follow-up. There's no point saying we had 10,000 patients who had X risk factors, and by the time we studied them for 10 years, out of the 10,000, we only studying 500 because the rest disappeared. We also must understand that the registries have to be representative of the population. Who are the ones coming to private hospitals? They're not representative of the population. Okay? So the ones who are coming to the public hospitals are neither represented, could be representative of some of the population, but the ones coming to private, yet a lot of data has been produced by the private hospital, far more than that could be done. But then that relates to therapies, and that could relate to advanced therapies. But grassroots level data is what's important for this country. Like I said, we rely on two scoring for outcomes of a coronary artery disease patient, and to reach his target levels, we rely on Western data. For even our own population statistics, we rely on multinational studies of which India was a part, and we start understanding what was the Indian population enrolled into their studies and are able to extrapolate that data to India. But the reason is, yes, it has to be when you say, why can't it be a hospital-based initiative? Exactly for the reasons I told you. Each follow-up and each registry requires expense and requires meticulous field follow-up. Field follow-up. It's not just he came to the institution once and we put him into a registry. He requires then years of follow-up. We, as an institution and others, have all done registries. But the sadness of it is that is our institutional registry only reflects the type of patient who will come to me, which only constitutes not the same person who sits in the small town and villages. I hope you understand that. That's crucial because it's representative of an upper class of the society who then we can follow up and can track and give him a phone call. So actual data, which is of the country, needs to have initiatives, exactly ICMR, government. Who's going to fund that, by the way? A follow-up needs funding. A follow-up needs ringing. A follow-up needs visit of a patient to the hospital. A follow-up needs tracking down. And no registry is, every registry is useless unless it has serial follow-up of 90%, greater than 90% of the patient over a serial follow-up of multiple years. Then only we say that what have we done, what is our substrate, how have we intervened, and how are they responding to our intervention. It's not just one visit to the hospital.
Yeah.
And to add to that, only a public body will be able to get all data on whether a person is alive or dead. So if you're looking at US or Europe as well, all the data on whether a person is alive or dead comes from a public from a public body. For example, in the US, it is Social Security, which is publicly available data, publicly collected data. Or in Europe also, there is population data that the government collects to know whether somebody is alive or dead. So that is not data that a private institution can access freely.
I would go, in fact, augment what Dr. Aditi has just said. Denmark, Norway, Sweden have some of the most fascinating registries of the world because every patient is trackable. Every person in the country is trackable, not just patient. Every person in the country is trackable. Everyone knows why he died, for what disease he died, what was it. Everybody can be tracked for admission, procedure, and discharge. It's a national database right from the birth to the end of his life can be tracked. Okay. That is why we get information. And that's why policies of the government and ICMR are more important for understanding these rather than just saying, why didn't I do a registry?
Okay. So when we are talking about data here, so I think we have last 5 minutes before I give it to Vikasar for winding up. I have one question on the AI. So without AI, we can't, finish an, webinar nowadays. So looking ahead, how will AI, telemedicine, any digitization, remote monitoring influence is helping prescribing the patterns and adherence of CVD? So we are talking about precision medicine, genomics is coming in, new drug classes are coming in. So with all these things, with the digital technology, can we manage heart disease in India better? Which therapies are showing the most promise for, if we can just talk about the digital aspect and CVDs. Dr. Aditi, first, if you can go.
So AI is penetrating all aspects of medicine, right from detection, diagnosis to management and patient care follow-up as well. So there are multiple roles where this is already being used and multiple areas where it is being tested as well and should be implemented in the near future. For example, detection. AI is being used to detect, say, from just a single lead ECG or even just from your smartwatch, whether somebody has hypertension or heart disease. So those are things that are already being studied and already being implemented as well. Then as far as diagnosis is going, in our own hospital, we are using it to diagnose patients better with, say, heart disease when they come to the hospital. When pregnant ladies come to the hospital, we are using digital stethoscopes, for example, to see if they have heart disease, and so on. There are lots of populations where interventions like this can be very helpful to diagnose and detect diseases. That's digital stethoscopes, using AI and ECGs. We are using AI to understand from our own electronic records, which are the patients who have heart disease, which are the patients who have low ejection fraction, that is heart failure. We We're also using AI to understand better which patients will respond to certain treatments. So if we have large data sets, we can look at those data sets to understand this group of patients is going to respond to certain types of medicines, and this group of patients is not going to respond to a certain type of medication. So we should use a different sort of medication. Then, as far as patient management and self-care is concerned, technology has a big role to play. A lot of patients are using smartwatches and gadgets to help them manage their disease better, track their blood pressure, their vital signs at home, helping with medication adherence also. That is a big one, as Dr. Tyagi had mentioned earlier, that people take a medicine for a month and forget to take it. That
Yes.
is where mobile-based applications, text messages, remote monitoring from doctors and nurses, that can be very helpful. There are also smart pill boxes that can give you reminders that you have to take your medications. And all of these, there are lots of mobile applications which can help you track your health condition as well. So definitely a lot of role that AI and technology has to play, and it is only going to increase in the future.
Yeah. Dr. Tyagi?
Yes. For me, AI is very important tool and emerging for accurate diagnosis. But most important for our country, like India, which is a very vast country, telemedicine has very important role because the rural population has the doctors are less, the hospital beds are less as compared to the urban population. But if we can transmit the ECG of a patient from a rural center to a specialized center for whether it is a heart attack or not, and mind you, most important factor in the treatment of heart attack is early treatment. First hour is called the golden hour. And it is not necessary that person should go for immediate angioplasty in a village. That we have injections which can dissolve the clot and can cure the heart attack that is occurring because of the clot. The clot can be dissolved and the blood flow restored. If one diagnoses with a simple ECG which is transmitted over a smartphone to a doctor, and this can be very well organized, and telemedicine should be the future of cardiology and medicine in our country. And every state, every village, every PHC should be linked to a center where early immediate diagnosis and early treatment can be given to that particular patient. So telemedicine will be having a bigger role. And importantly, as I would say, that for the person, it is important to recognize the symptoms of heart attack and seek early medical interventions and go to a doctor, get your ECG done, and 90% of the time you can accurately diagnose whether it is heart attack or not, because most of the death due to heart attack occur within the first hour. And if you can get the treatment within the first hour, you can prevent the damage to your heart. And if the heart gets damaged, then heart failure occurs and you cannot salvage by any drug or any therapy.
Okay. Dr. Seth, your observations on the digitization, AI.
So we got to differentiate the digital transformation from the AI. Uh, Dr. Tyagi has talked wonderfully about the digital transformation, and it is the need of the hour, but it's not just the need of the hour. Thankfully, our Honorable Prime Minister is the biggest proponent and has been pushing for the digital, in fact, augmenting at every part and in every ecosphere the digital transformation of our country. Right from the way we now get into an airport to how we even use a pay through any of the apps, to the fact of taking an EKG in a remote center and transmitting it to us, monitoring diabetes, monitoring hypertension is all digital. And it's clearly the reach of digital in our own country, and perhaps through cell phones and the network which exists, is one of the largest in the world. So for us, digital is already become a part. We are far more digital than most of the advanced countries in the world, I must tell you that. And our reach is growing in every sphere. You just probably don't see it as much because it's just becoming a part of life.
Yes.
Okay. Even when you scan a QR code and pay a vendor, is not seen in most of the advanced countries. Uh,
Yeah.
but AI is a whole different tool. And yes, AI is valuable. Its valuation, its ability to help us as specialists across is undoubtedly going to be a frontier. But at the moment, AI is I think we need to transform the digital world far more because we're talking about grassroots. How AI is going to assist us when we reach those grassroots is a companion to us. But AI will not go downstream to the grassroots because it's going to be the digital world going down grassroots, AI assisting that to make sure that appropriate therapies are delivered. For example, we got the grassroots and have phones taking EKGs or echoes, phones taking EKG and echoes with all that information of a 10,000 people suddenly flooding into us. It will need an AI, not me sitting here to say, that ECG is okay. Okay. Oh, I'm flooded with EKGs. I've got 500 EKGs to see today. There'll be an AI saying, this 2 EKGs is what you need to see. The rest are all normal. The rest don't
Makes
need
it
any
easy
treatment.
for the doctors as well. Yeah.
It's easy for healthcare deliverers to go downstream, but it's going to be digital transformation which is going to help the people downstream when we talk about the common man and we talk about community. At our own level, in super specialized hospital, AI going downstream, especially for radiology, especially for ICUs, especially for that, it'll all be AI generated to help more and more people. But digital transformation is going to be the integral hub with spokes from AI.
Yeah. So with that, I would like to give it to Vikas sir. And there was a query from the one of the listeners whether this recording will be available. Yes, it will be available in our portal. It will take some 3-4 days, but still we'll have the recording there. Vikas sir, over to you.
Right. Thank you so much, all our expert speakers. I think we had it all 360-degree covered, very comprehensive. We started with community-based approaches, which was very important, to start the discussion. Dr. Seth mentioned very clearly about the need of awareness and treadmills by the side of corporate canteens, less samosa, more running, probably. The need of data, the precise data that we need for India studies, not India as part of global clinical trials, extremely important. The emphasis that Dr. Singhvi gave about LDL tests, I mean, that's again something that is gaining importance, and the new treatment regimens that are coming. In fact, use of AI, new therapies, telemedicines, digital transformation, the last point that was made by Dr. Seth. I think these are all very, very important questions. Hopefully, these will definitely see a curve coming down. Hope the bending will also happen. Right now, we are seeing a spike. So, thank you so much, sir. We will keep coming back for your expertise and ma'am. And thanks so much for your continued support to ET Health World. We'll try to expand this even more further and more deeper. So thank you so much, and thank you, audience, for being there, patiently listening, and also taking the notes. Thank you again. Thank you.
Yeah,
Thank you.
thanks to all the three panelists, Dr. Tyagi, Dr. Seth, and Dr. Singhvi. We'll keep bothering you, not just for World Heart Day. We will be coming back to your expertise, opinions. Yeah.
I'll just say it's not running after samosas, it's running without samosas.
Well said. Absolutely. Point taken, sir. Yes.
Yeah. We will try our best.
Thank you.
Thanks a lot. Thank you. Thank
Wonderful.
you so
Thank you.
much.
Thank you so
Thank
much.
you.